Good afternoon, everyone. Thank you, Dr. Rajshekhar and the team for giving me this opportunity to be standing in front of you today to talk about a topic which Dr. Rajshekhar has thought I should give it to me. Refractory angina in patients who have a non-revascularizable coronary arteries. Angina is the commonest clinical symptom we see in our clinical practice, and it is the commonest clinical manifestation in coronary artery disease. About 10% of the patients continue to have severe angina in spite of the best of the anti-anginal therapies, in spite of revascularization with a stent, in spite of revascularization with a bypass surgery. And the problem is going to grow. The problem is going to grow because the treatment of coronary artery disease has improved dramatically. The revascularization strategies are really to the best what we have seen in the last 2 or 3 decades. The patients are getting older, and the burden of the patients with more complex, severe calcified coronary artery disease is increasing. Having said this, let's look back at the definition of angina, which was given by William Heberden in 1772, and very aptly, very beautiful description of angina at his lecture in the Royal Society in London. The classical presentation of angina, where they're seized while they're walking, especially uphill or postprandial state, with a painful and a most disagreeable sensation in the chest, which seems as if it would extinguish life if it were to increase or continue, but the moment they stand still, all the uneasiness vanishes. The typical angina, the typical clinical symptom of angina of myocardial ischemia was described by William Heberden in 1772, but angina is only a tip of the iceberg. What happens before angina is much more important. The first step when there is a myocardial ischemia is a decrease in the relaxation or the diastolic dysfunction. Subsequently, systolic dysfunction sets in, and then the filling pressures rise, and then only the ECG changes start happening, and then you have angina. So angina is at the end of the ischemic cascade, not at the beginning of the ischemic cascade. A host of 4 important steps do happen in the myocardium before angina is perceived by the patient. And approximately 1/2 of the patients with angina also experience asymptomatic episode, that is silent ischemia. Many episodes of ischemia never become painful because there is some amount of neuromodulation at the spinal level and even at the thalamic level to prevent the ischemia perception to happen there. So what is important is that the angina symptom itself is very, very important, but what is important is the refractory angina, what we are going to speak today about. And that's the definition of refractory angina. It's a long-lasting symptoms of angina for greater than 3 months due to established reversible ischemia in obstructive coronary artery disease. So the symptoms are there for a long time in spite of the best of the anti-anginal therapy. They cannot be controlled by the escalating medical therapy with the use of second-line drugs or third-line drugs, bypass grafting or stenting, and they continue to have recurrent episodes of angina. In spite of the best of the treatment, we do see this happen quite often, especially in patients who have had a recent bypass surgery or a recent angioplasty and a stenting. The patients come back to us recurrently with chest pain, which is typical of angina, and when you do a repeat angiogram or a repeat CT coronary angiogram, you do find that the vessels are patent, widely patent, no significant disease, if at all a mild disease, and the patients continue to have a significant angina. Now, this is the group of patients who have a microvascular dysfunction and a microvascular dysfunction leading to a typical anginal symptoms which is there. So it could be related to a coronary vasospasm or a coronary microvascular dysfunction, which can also occur in association with obstructive or non-obstructive coronary artery disease, and it could be seen in the setting of both obstructive and non-obstructive coronary artery disease. So it's very important that we do realize these patients and we categorize them appropriately. The goal of the patient, for the patient, is that I need a treatment. I need to reduce my episodes of angina. Will any of these anginal episodes result in a myocardial infarction? Will I die? And can you improve my quality of life? Now, these are the goals which the patient sets for himself, but what is important is that angina does occur in about 75% of the patients who have one of the studies, in fact, this is the Optimist trial, which has clearly shown that patients with angina and recurrent angina episodes with chronic stable angina do continue to survive for long times. People live with it people don't die with it. And that's the important statement which I want to make there. About 2 to 20% of the patients with angina are severely limited by the angina, and the burden for angina continues for this group of patients in spite of the best anti-anginal therapies there. So we know from a number of registries and trials that the presence of angina is associated with an increased cardiovascular events, but what is more important is it does impact their quality of life. They cannot perform their daily activities, they have a change in their family relationships, interpersonal relationships. They are always at a stage wherein they fear that one of those episodes of angina could convert to a myocardial infarction. Also, the burden on the healthcare system is quite obvious there, which was clearly told by the previous speaker. So it's not just that the angina is just because you have a stenosis in the coronary artery. It is a complex interplay of various pathophysiological mechanisms which happen. One of them is just not that it's not just the epicardial coronary artery stenosis, but probably so it's the microvascular dysfunction also which could be contributing to the and the interaction between the heart muscle and the microcirculation. So a combination of the epicardial stenosis, the microcirculation, and an interplay of the microcirculation with the cardiac myocyte leading to a host of situations wherein the blood flow is reduced and the perception of angina occurs for this group of patients.